An adolescent male presents to the emergency department following minor head trauma. I am showing you a skull radiograph. Describe the findings.
Right, so the skull radiograph demonstrates no acute calvarial fractures, depressional injuries, or diastasis of the major sutures. However, there are multiple accessory intrasutural ossicles, or Wormian bones, lining the lambdoid and posterior sagittal sutures. Given the patient's adolescent age, the presence of numerous Wormian bones is pathological. The bone density of the calvaria is otherwise normal. These findings are diagnostic of multiple Wormian bones.
Define Wormian bones, state where they are typically located, and explain the criteria for when they are considered pathological.
Wormian bones, also known as intrasutural bones, are accessory ossicles that form within the cranial sutures. They are most commonly located within the lambdoid suture, followed by the posterior sagittal and temporosquamosal sutures. While they can be a normal variant in healthy infants under 1 year of age, they are considered pathological if they persist beyond the first year of life, or if they are large and numerous, specifically defined as more than 10 in number and measuring greater than 6 by 4 millimeters.
Provide the comprehensive differential diagnosis list for multiple pathological Wormian bones and suggest a helpful mnemonic.
The differential diagnosis can be remembered using the Mnemonic Porkchopsi. P stands for Pyknodysostosis, O represents Osteogenesis imperfecta, R stands for Rickets in its healing phase, K represents Kinky hair syndrome or Menkes disease, C stands for Cleidocranial H stands for hypothyroidism or hypophosphatasia, O represents otopalatodigital syndrome, P stands for pachydermoperiostosis, S stands for syndrome of Downs, and I represents idiopathic causes.
How can other radiographic features help narrow down the differential diagnosis for Wormian bones?
Specific calvarial and skeletal findings can help differentiate the etiologies. Osteogenesis imperfecta and healing rickets will show generalized osteopenia, with Osteogenesis imperfecta also exhibiting long bone bowing and multiple fractures. Pyknodysostosis will present with diffuse osteosclerosis of the skull and skeleton. Cleidocranial dysostosis classically features absent or hypoplastic clavicles, widened pubic symphysis, and multiple supernumerary teeth. Hypothyroidism may show delayed skeletal maturation or epiphyseal dysgenesis, while Menkes disease shows metaphyseal spurring.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this skull radiograph with prior cranial films to assess chronicity. I would suggest checking the clavicles on chest or shoulder radiographs to evaluate for cleidocranial dysostosis, and checking skeletal surveys for fractures, osteopenia, or osteosclerosis. I would recommend correlation with clinical history, developmental milestones, and serum calcium, alkaline phosphatase, and thyroid function tests. Finally, I would document the findings, state the differential diagnosis, and refer the patient to pediatrics or genetics if systemic anomalies exist.